Thank you for attending first session of 2022. Next slide, please. As always, very grateful for Dr. Galandiak, the leader of the journal, and congratulations to her for her anniversary. I'm not sure what number it is, but it sounds important. Next slide, please. So our guidelines and disclaimer. Next slide, please. Today we are in Sao Paulo. I'm very excited to have this session hosted in South America. This is the first time we've ventured down to a new continent. We've had one session in the UK, but this is the second sort of international session, so to speak. I kind of mentioned what I found interesting is that because of the discrepancy in the city and the different soccer teams or football teams, there's even sort of metro distribution of how to go from one stadium to the other, which was interesting. But now I'll let Dr. Perez introduce his city, introduce his hospital and his team, and we'll go from there.
Well, thank you, Vlad, and thank you all for the kind invitation to participate. And I've selected these two pictures because the picture on the left is really what the skyline looks at in Sao Paulo. When you fly in Sao Paulo, you cannot actually see the end of the city because it's so large. There's so many buildings around. It's very difficult to find and see the end of the city. So it's quite unique and quite significant. Now, the second photograph, I'm probably guessing a lot of people were thinking that I put this on, and I think even Bruna and Guilherme that work with me, thinking that I put this picture because this is the park. This is what would be the central park for Sao Paulo. And they're probably thinking that I put this picture on because I like it very much, because I go running every other day in this park. But the truth of it is, this is the actual view from Professor Angelita's balcony, where she lives. This is the actual view from the park, looking from her balcony. It's quite a unique place to visit. If you ever come to Sao Paulo, give her a call. We'll manage to do that. Next slide, Maggie, please. So this is the hospital we work with. We're an institute that is affiliated with the German hospital in Sao Paulo. This is what it looks like. You can see the two most relevant and most important people in this institute, which are Professor Angelita and Professor Joaquim Gama. They're married to each other. Professor Angelita is obviously a colorectal surgeon. Professor Joaquim is an upper GI surgeon, so a perfect match. And I have to say, I'm privileged and honored to have the opportunity to work and still work with both of these very important people in our country, in Latin America, and in the world. Next slide, please, Maggie. So this is our group. This is our colorectal surgery group. You can see Professor Angelita, myself here, Manuela, who is also one of the colorectal surgeons that work with us, Bruna and Guilherme, who are both connected with me today. We're going to discuss some of the two papers talking about organ preservation published in DC&R. And rather than looking at the data itself, we're gonna go in between the lines of these papers to look at the some of the problems and some of the cautious views that one might have to look at when looking at these papers. So thanks again, Vlad. I think this is my last slide before we start discussing the papers themselves.
Thank you. So we have a poll. So you can please, at your leisure, have a read of the question, and pick whichever one you think is the most appealing to you. And I think, without further ado, we'll have the next slide and start the paper. And thank you very much, Dr. I'm sorry, I stuffed this up. Guilherme.
Guilherme is the Brazilian name for William, so you can call him William for the purpose of this discussion.
Okay.
Thanks for the introduction, Vlad, and thank you everybody for having us here. Good evening to everyone that's listening. So in the next few minutes, I will summarize this interesting paper that was published in DC&R last year. So this is a retrospective study where the data was retrieved from a prospectively maintained database. This is an interesting concept. And it was conducted in the Memorial Sloan Kettering Hospital in New York. Patients were treated between 2012 and 2019. And the objective of this paper was to identify the proportion of patients that could benefit from watch and wait. Next slide, please. So very briefly, the inclusion criteria for this paper were patients with rectal cancer up to 13 centimeters from the anal verge. So having the tumor reachable by a finger was not an inclusion criteria, and was mandatory that these patients had an initial MR and had an initial assessment by the colorectal surgeon. So all these patients were treated by one single colorectal surgeon. All patients underwent the treatment with induction chemotherapy. So they have TNT, total neoadjuvant therapy, which was induction chemotherapy with either FOLFOX or CAPOX. And they had then the chemoradiation therapy, which was planned to have 56 grades of radiotherapy over a long period. So it's a long course chemotherapy, simultaneously to capecitabine or 5-FU chemotherapy. Then after 8 to 12 weeks, these patients were reassessed. Just to point out some exclusion criteria, so T4 tumors were not included. Patients that were previously randomized to the ULTRA trial were excluded. Any other kind of neoadjuvant or TNT treatment were also excluded. And patients with initial diverting stoma or that were not assessed by this colorectal surgeon were also excluded from the study. Next slide, please. So once the patients finished their treatment, they were assessed 8 to 12 weeks after the completion of the radiotherapy. Those with a complete clinical response were offered watch and wait. Those with an incomplete response were offered total mesorectal excision. And then I'll call your attention here because some of these patients did not have a complete, neither an incomplete, they had a near complete response. And for these patients, it was recommended to reassess in 6 to 8 weeks. And then those that had an improvement were recommended observation, and those that did not have improvement were recommended total mesorectal excision. Next slide, please. When we look in the results, 88 patients were started TNT. One of them passed away during the treatment. Out of the 87 that concluded the treatment, 32 had a complete clinical response and underwent the watch and wait protocol, with only 2 having local regrowth. That means 6%. The other patients were treated with TME or local excision. If we look at the comparison among those that had watch and wait and those that had surgery, regarding the treatment, there was no difference, but it's important to call your attention to that both groups had lower dose of radiotherapy than planned. It was planned 56, and both groups had a median of 50 grays of radiotherapy. And we had a toxicity around 25 to 35%. Regarding the initial baseline features from those both groups, the watch and wait group included patients that were older with distal tumors with similar initial staging and had smaller tumors. And if we look only on the group that were operated, obviously, we had 11% of pathological complete response. Next slide, please. And then finally, looking at the oncological outcomes, out of the local regrowths, as I said previously, only 2 patients had local regrowths. One of them had a local excision for an adenoma 20 months after TNT. We can even discuss later if this is really a local regrowth or not, as adenoma is not a tumor. And the second one had an APE 17 months after TNT, followed by some liver and lung mets, and eventually died of the disease. We have an average follow-up, a median follow-up of 42, 45 months for both groups, with the group that underwent the watch and wait had a better disease-free survival and a similar overall survival. And it's important to look here that we're not talking about the same kind of patients as patients that had watch and wait. They had an amazing response, even if they had local regrowths. Next slide, please. So the authors concluded that with this kind of treatment, TNT with induction therapy, 30 to 40% of these patients had a chance of organ preservation following this treatment. Okay, thank you. I think, I don't know if we can go for the questions or if I can give some comments on my opinion about this study.
Yeah, please. If an opinion about the study would be fantastic, and then we'd also get Dr. Perez to say a few things, and then we'll see if we can get some questions and pointers from the audience.
So
Go ahead,
I think this is a very interesting data from a very important institution, and the most interesting data that we have here and that we see here that's a bit different from what we usually see from other papers is the rate of local regrowth. So this group presented a rate of local regrowth of 6%, and usually is around 25 to 30%, what's pretty higher. And then I want to remember you from the method slides when we talked about the near complete responders. And this is always a problem to identify exactly what's the denominator of patients that are at risk of local regrowth. Because if this group of near complete responders were, as in the initial assessment, they were recommended to observation, they were included in the denominator, probably the rate of local regrowth will be higher, as those that did not properly develop a complete response would be classified as a local regrowth. On the other hand, if we only use the denominator for those that had a true complete clinical response, then the denominator will be smaller and the rates of local regrowth will also be smaller. So this is always a big challenge when we read a paper about watch and wait to identify exactly what patients they're talking about the rate of local regrowth, as this is the main issue that usually people think when they offer patients for watch and wait. They're concerned about the local regrowth rates, and this is one of the main issues. I think this is the point more interesting that I found from this paper. I don't know if Dr. Perez want to say something else for the points.
Yeah, I'm gonna go backwards a little bit, Vlad. So, and I'm gonna leave this final point that Guilherme has raised, which I think is an important one, but it's not easy to understand straightforward. So, and it gives us a link to the next study. So I'm gonna leave it for last. Okay. So my first point is, this is a paper talking about TNT, okay, but it's talking about induction therapy. And induction therapy is quite interesting because induction therapy, we probably know it's almost dead, because, you know, consolidation chemotherapy as opposed to induction chemotherapy has shown to result in better response and similar survival from the preliminary data from the OPRA trial, but also from the randomized control trial performed in Germany. So it's interesting because induction therapy is somewhat dead in terms of providing any benefit for patients with locally advanced rectal cancer. Still, it's quite a significant number of patients being treated by induction chemotherapy. So problems, and everybody has to think about this when they read a paper like this, is we're talking about consecutive patients being treated by induction chemotherapy. Now, they're not talking about consecutive patients with rectal cancer. They're talking about consecutive patients where they decided to give, for some reason that we don't know, induction chemotherapy. This is quite different from consecutive patients with rectal cancer being treated by induction chemotherapy. Now, careful, because when you read the paper, it gives you somewhat the impression that, you know, consecutive patients with rectal cancer are being treated with induction chemotherapy, and then you have a 30-40% complete response rate. This is not what the paper is actually talking about. The paper is talking about patients who underwent induction chemotherapy for some reason, which we don't know. Those patients had 30-40% complete response rate. Quite different. Another important point is the fact that they're treating patients for organ preservation's sake throughout the rectum. We, and Guilherme has alluded to this, we as a group, we believe that rectal cancer and organ preservation should be, at least at this point, restricted to patients with very distal cancers, not up to 13 centimeters from the anal verge. I would probably challenge the authors that above 10 centimeters, these tumors are probably intraperitoneal. There's probably very little benefit in offering these patients organ preservation strategies. Still, I understand that this is now being done in this way, and many of these patients probably had high-risk features, and that's the reason they received induction chemotherapy in the beginning. Still, I believe, or if we believe as a group, that TNT and organ preservation should be restricted to the very distal ones. Third comment is they had an 11% PCR rate, which is quite intriguing. If we look back at our own data, we have, it's been a long time since we operated on a patient with a complete pathological response. So I was kind of surprised with such a high rate of a complete pathological response, in addition to the 30-40% complete clinical response rate, which is quite intriguing. Now, the last comment is really important, which Guilherme has alluded to, is when do we start saying the patient is being managed by watch and wait? When do we call it a complete clinical response? Because if we call a complete clinical response whatever is a near complete response, then the local regrowth rates go higher up. Now, if we only consider those who have achieved all strict criteria of what a complete clinical response is, and we move away or take away all of the near complete responders, then the local regrowth rates go down. And this may have been the case here, where they report on a 6% local regrowth rate, which is actually very low. And I believe one of the reasons for this is we're only looking at those patients that after a significant amount of time turn out to be complete clinical responders with all strict criteria. So the question is, when do we call a complete clinical response? And this is why I mentioned that this is a perfect link for the next paper, which Dr. Vailati will talk about. And I'm not sure we have any questions from the audience or the chat.
I don't think there's any yet, but I was hoping to actually get you to expand on two things. So you mentioned about the complete clinical response, and reading what the author said, so they say all patients entered into the watch and wait protocol underwent a digital rectal exam, regardless of whether the tumor was reachable by the examiner's finger. So to get a definition of complete clinical response, do you think that it needs to be palpable and you need to get an MRI and an endoscopy, or like what is the criteria for assessment in your center?
So in our opinion, the criteria for a complete clinical response depends on three pillars. First pillar, and perhaps the most important one, is digital rectal examination. This means a tumor that is not accessible to the finger is probably not a candidate in the beginning for an organ preservation strategy plan. Patients have to present with tumors that are somewhat accessible to the finger. First, because these are the patients that benefit the most from organ preservation. Second, because you have a brilliant tool to assess tumor response. Now, remember, when Professor Gama envisioned this and started this program, MRI was not around. It wasn't bad. It wasn't even around. All she had was the finger and the eye. So I believe, we believe as a group, that being accessible to the finger in the beginning is an inclusion criteria that has to be observed for patients considered for organ preservation. And after completion of chemoradiation therapy, it has to be in one of those three pillars, which are digital rectal examination, endoscopy, and radiology, including high resolution MRI.
Thank you. My second question is again on something that you've mentioned about low tumors. Now, I think there's a difference between an APR and a reconstructible cancer in terms of, you know, patient decision making for a number of reasons. Do you think the control group, when comparing complete pathological response with watch and wait, should be APR, or is it, you know, or is the potential reconstructibility, you know, not a factor? And also, is there any association with distal recurrence for something which potentially involves the sphincter versus something which is higher in the rectum?
So I think that the control group, we're talking about patients with organ preservation, the control group has to be with the baseline features blood. So we have to look at patients at baseline features. So patients have to present with low cancers that need to be at the level of or 1 centimeter above the anorectal ring, seen by the MR, and not necessarily the procedure we perform. Because when you introduce the procedure, there's a surgeon variability. So the variable surgeon comes into place. And I don't think that's a good variable to include in any study of organ preservation. We need to look at tumor features and not much for procedure features. Now, if you really want to use this as a controller, maybe I would say APR, but also coloanos and intersphincteric would probably also be a good control group for patients who are managed by organ preservation. Can you repeat the second question?
I think that was a very good answer. There's a few other questions going on. I might leave that one be. There's one question for the chat about the definition of a near complete response, but we might leave that for the next paper because I think it might be a bit more helpful there.
I really like that question because it's very easy to respond.
Okay, go for
Lynn, there is no good definition of what a near complete response is. I completely agree with you. And that's the problem that we have. We are trying to achieve a consensus of what a near complete response is, and to tell you the truth, we're not being able to do so. To be honest with you, there's not even a consensus of what a complete response is. Imagine what a near complete response is. It's very difficult, and I completely understand. And this is one of the major problems, and it's absolutely subjective. And many of us are doing this without a very good definition of what a near complete response is. Can I answer the last question in the chat? Sami?
You can, but can I just be on the same train of thought? I just wanted to mention sort of the MRI staging being a bit of an Achilles heel. And before we get to Sami's question, the authors say patients with smaller tumors do better, which seems obvious. With intra-observer MRI sort of variability, you can make an argument that, watch and wait favors tumors which may have been upstaged with the MRI reports. So what is the strict MRI assessment that you use? And then obviously, if you can then expand on the EMVI, extramesorectal disease, and that in the same question.
Sure. So number one is, so the baseline MR features are not necessarily an exclusion criteria for organ preservation or for the achievement of a complete response. Now, I have a problem with the assessment of the MRI. Now, MRI is a very interesting tool. It's much more recent than endoscopic assessment and clinical assessment. And honestly, to be honest with you, we as a group, we've been taught and we've been practicing organ preservation more relying on the digital rectal examination information and the endoscopy and using the MR to support our findings, number one, or to see residual mesorectal disease, which is obviously impossible to be accessible by the finger or the eye. So we usually use MRI more as a support to our endoscopic and clinical findings rather than the other way around. And I'm quite nervous when I discuss patients and cases with some of the people around the world. Well, they present a case and the first thing they want to look at is the MRI, and they're missing the point that the finger and the eye are to be considered the most relevant. And I honestly use the MR more as a support to what we find, and obviously to look at the mesorectum, because often we see a lot of residual mesorectal disease, and about 10% of these patients will have residual disease. So that's my response to the MR. Now, Sami's question is, I'm not sure we're going to find a place for induction chemotherapy, and we can discuss hypothetically, but the truth of it is, when you look at the randomized clinical trials, Sami, there is no benefit of using induction chemotherapy as we speak now. And I love the discussion with the medical oncologists because they love induction chemotherapy. But to be honest, it's like we're looking for a place in the sun for induction chemotherapy, but we haven't found it so far.
Thank you very much. There's another question in the chat, but I think in the interest of time, we've got a fair bit to go through. Maybe we can start the next paper. Now, the next paper is called Achieving a Complete Clinical Response After Neoadjuvant Chemoradiation That Does Not Require Surgical Resection. It is by you guys, your group, which is fantastic. And can we please have Dr. Violati to present this paper?
So the next paper is based on the idea that tumor regression rates after neoadjuvant chemoradiotherapy may be higher when patients are followed for longer intervals, and that the newer regimens of neoadjuvant treatment can increase the rates of complete response. So the study hypothesis was that longer intervals from neoadjuvant treatment may lead to higher rates of complete response in rectal cancer in the setting of these more intensive treatment regimens. The study evaluated consecutive patients with distal rectal cancer undergoing neoadjuvant treatment with radiation dose escalation and consolidation chemotherapy who had clinical complete response to determine the time between completion of treatment and the assessment of a clinical complete response. Next slide, please. It is a retrospective study including patients with non-metastatic rectal cancer, 7 centimeters or less from the anal verge, who received the same neoadjuvant treatment and were staged as T3, T4, and positive or very low T2s. The neoadjuvant treatment was based on a 54 grays dose of radiotherapy and cycles of 5 FU every 21 days. Next slide, please. The first assessment was 10 weeks from radiotherapy completion, and patients with suspected clinical complete response were reassessed every 6 to 8 weeks until all the strict criteria for clinical complete response were met. Here we can see our criteria used for complete response and suspected complete response, as Lynn asked before. The study outcome was the time between radiotherapy completion and the achievement of strict clinical complete response defined by clinical, endoscopic, and radiologic assessment, and only patients with sustained clinical response were included in the analysis. Next slide, please. 49 patients had sustained complete response, which were the population of the study. And we can see that more than 60% of patients took more than 16 weeks to achieve complete clinical response, with a median interval of 18 weeks. Next slide. Patients with earlier response had no difference in pre-treatment characteristics when compared to patients who took more than 16 weeks to complete response. However, when we use time as a continuous variable, patients with T2 and T3A tumors achieve complete response earlier when compared to patients with more advanced tumors. Next slide. And the study conclusions are that a significant proportion of patients only achieve a formal clinical complete response after 16 weeks from radiotherapy completion, and that we can lose the opportunity of organ preservation in patients with excellent response if treatment decisions were taken between 10 to 16 weeks after treatment. And more advanced tumors may take longer to achieve clinical complete response.
Yeah, we'll do the poll and then we'll discuss the paper.
Okay.
Stephen.
Yeah, I'm bringing up the poll responses. So again, the question, just to reread it, was what in your practice would preclude you from starting a watch and wait program for your first line therapy for patients with non-restorative, generally distal, curable rectal adenocarcinoma? There's a fair amount of positivity, 42% were ready to go. And then there were certainly some people that were in the middle ground waiting for longer term data. And then resource allocation is 20%. So certainly a number of people that at their institution felt like they weren't ready structurally to handle this program. And then there's certainly also some that felt that the standard of care needs to be rewritten to include this for their, usually for here, the US standard of care.
Okay.
Okay. So Rodrigo, are these results surprising to you? You've been doing this for a long time. Do you think they're different from 5 years ago? Do you think that what do you expect them to be in 10 years' time? Where do you think things are going?
Well, I think we gotta be a little bit more careful. And in the beginning, I remember at the time when it was only us, and I would come with Angelita to these meetings, and people would look at us as the Martians or something like that. What are we doing with rectal cancer, not operating these patients? And I think we're kind of going to the other end quite quickly. So I'm a bit concerned, people doing a lot of watch and wait to any patient with rectal cancer, undergoing any kind of treatment, any stage, and not properly assessed after chemoradiation completion. And I think we gotta go somewhere in the middle, as with anything in rectal cancer, probably anything in medicine. So I'm a bit concerned that people are not taking the time and effort to properly assess response. And the paper that Bruna has, brilliantly presented here is really a very simple paper. And I think it's simple papers sometimes give you interesting and useful information. Now, number one of this paper is, and I'm obviously biased because it's our paper, and I think the reviewers from DC&R that actually did this a much better paper than it was in the beginning. And I think it's the simplicity of it is one, we're really talking about consecutive patients. So we haven't treated anyone else differently. All comers would have received the same treatment strategy. We were not treating patients with induction chemotherapy. We were not treating patients with standard old-fashioned chemoradiation therapy. So all patients underwent the same treatment strategy. That's number one. And we're simply looking at the time elapsed between the termination of radiation therapy and achievement of complete clinical response, and trying to use a strict criteria of what a complete response is. Now, obviously, the paper has problems because, number one, it's a retrospective study, so we're not really sure what was mentioned in the charts really had to do with what we were calling a strict criteria of a complete clinical response. So there are problems in respect of being a retrospective or the retrospective nature of the paper. The second problem is we were not seeing patients every week to be sure when patients actually achieved the complete clinical response. It really depended on when the patients came back for assessment of tumor response for them to be called a complete response. So sometimes the patient simply missed a consult and came to the next consult, and we thought it was a complete clinical response achieved at 16 weeks, but had the patient come at 10 weeks, he could very well have already a complete clinical response. But the truth is, we will never know until we have a study looking at patients every week to be sure when these patients are actually achieving a complete clinical response. However, it does provide us with an interesting information that a lot of these patients at 16 weeks or so had not yet achieved all strict criteria of a complete clinical response. And it brings us back to Dr. Lin's question, is, so what is a suspected complete clinical response? What is a near complete clinical response? And when we discuss patients, Lin, today, I would say that for us, a suspected complete clinical response is when we have at least 2 of the 3 pillars saying this is a complete response. So if you don't feel anything with the finger and you don't see anything with the scope, and even if MRI is not perfect, this is a near complete response, and this is very, very much subjective. Now, consider the other way around. MRI says is a complete response. You don't see anything with the scope, but you still feel some irregularity. This is also a complete clinical response, a near complete clinical response. So these are the patients we would consider as suspected for a complete clinical response. These are patients that we believe should definitely have the opportunity to have a second assessment of response to see if this is improving or this is not improving, and make up our decision whether this is a complete clinical response. So I think it's an important paper because it points out the fact that not all patients achieve a complete clinical response at the same time. And number 2, that a quite significant amount of these patients may only achieve all 3 criteria after 16 weeks of completion of therapy. So you have to be and take this information into account if you're interested in offering these patients the chance of organ preservation.
Thank you for that. Now, I've got a question for either yourself or Dr. Violati. So in the paper, it says, of the 80 patients in the complete clinical response, 9 underwent a local excision, of which all were benign. I didn't quite understand how and why it was a local excision. Was this a definitive biopsy, or, did you elect to do this as opposed to a TME when you were concerned of cancer? Can you just tell me about the thought process, please?
Bruno, you want to take this question or want me to take this question? She wants me to take the question. Okay. So a number of patients, Vlad, and this is important for the audience here, a number of patients, approximately 10% of patients, will have a complete clinical response, but will still harbor residual adenomas in the periphery, usually, of these tumors. Some of these patients will have what we see as residual adenoma. So the primary tumor is gone, the adenocarcinoma component is gone, but sometimes we have residual adenoma. That's number 1. There's a second subgroup of patients where we still have irregularity that is not going away, MRI says it's a complete response. Endoscopy says, I don't see cancer there. And there is still irregularity. So these are the examples of patients that we would otherwise consider for a full thickness local excision, because either we're thinking that this is a residual adenoma, or we're not convinced that there is cancer there, but there is some irregularity we have to deal with that is not going away. So these patients, we would consider a complete, a local excision as a method of treatment and of diagnosis. Now, we've gone away a lot during the last 5 years, I would say. We've gone away of using local excision as a method of assessment of response because of the morbidity associated with the local excision in this setting. So we would probably rather wait a little longer instead of doing so much local excisions, unless we're looking at residual adenomas. The residual adenomas will not go away and will probably grow back again into a primary new cancer if you allow them to do so. So patients if you're convinced that there is a residual adenoma within the area of the tumor, of the primary tumor, you should probably locally excise it, because it's not going to go away and you're probably going to have to deal with a local regrowth. Does that make sense to you?
Yeah, that's actually incredibly interesting. I didn't think about the adenomas. I often wonder what happens to polyps left in sort of the proximal colon after doing a resection. And if it is just an adenoma, do you still do full thickness, or can you sort of just do a?
Yeah, we don't have data to support either local excision full thickness or partial thickness. We have actually been surprised with a few patients who had local adenomas, residual adenomas, and when we resected full thickness, there were a couple of cancer cells left within the rectal wall. So currently, when we see a residual adenoma, we might as well resect the entire scar to make sure what we're dealing with here. So patients who have residual adenomas, our preference is to do a full thickness local excision of the entire scar to make sure we're not leaving anything behind.
Thank you. Now, in your paper, you mentioned that your regimen for delivering chemotherapy as well as radiation is higher than most other centers. How did you evolve to the dosage that you use? And do you think that the findings of the study can be translatable to, centers that use lower doses?
So that's a very good question, Vlad. If you look at the first study presented by Guilherme, the induction chemoradiation therapy treatment that was used at the Memorial Sloan Kettering used or intended to use 56 grays of radiation therapy, which is already more than the usual 50.4 grays of radiation therapy. Now, we've been using 54 grays for quite a long time, and actually is a very small increment, because we're giving the same 45 grays to the pelvis, and instead of 5.4 grays of boost, we're now offering 9 grays as a boost. So we're not delivering more radiation to the pelvis. We're simply incrementing the boost that is delivered to the primary tumor and the surrounding mesorectum. And it doesn't affect so much the toxicity. Now, if you look at the data from the induction chemotherapy presented by Guilherme in the Memorial Sloan Kettering series, and that was the same observed in the OPRA trial, patients who received induction chemotherapy had a higher chance of receiving less than the intended dose of radiation therapy. Now, we strongly believe that radiation plays a central role in organ preservation. So if you're thinking about organ preservation, you really want to give patients the full dose of radiation therapy. And if you start doing induction chemotherapy, there's a higher chance you will not be able to offer these patients the complete dose of radiation therapy. So you've got to be careful with that when you think about organ preservation and induction chemotherapy.
Thanks for that. There's a comment from the audience about, in your experience, does the duration to achieve a complete clinical response correlate with a risk of local recurrence? I assume that's more persistence than the adenoma evolution, but
that's a good question. I'm not sure I can, if we look at the patients who achieved a complete clinical response, there was really no difference in the time for achieving a complete clinical response and the risk of local regrowth. But the numbers are so small, it's difficult to make, to support these findings. It's very difficult because we don't really know. That's one of the things we don't know yet. Experience kind of suggests that there are no differences on the time you achieve a complete response. But the truth of it is, we don't really know that yet.
And we have a lot of patients who regrowth in a few weeks. So I think in this study, we didn't give the importance for the first assessment, which we're doing actually earlier now, because we had a few patients who were assessed with 8 weeks and they had a complete response, and with 16 weeks they had a small lesion. So if the patient was seen for the first time with 16 weeks, I'm going to see this patient as a good responder, and he's already regrowing. I think it's
right.
The first assessment is really important.
That's very interesting. There's another comment from Dr. Wright, but I think it's a great comment, but I think it opens up a whole different area of the rectum that we debate. So I might leave it for today. I've got, as a segue to the next segment, you've mentioned before how initially when you were touring the different conferences and you were sort of probably not as adopted as now in terms of the management. How did you find, or how did you and your team find publishing on rectal preservation, or particularly publishing on something which is controversial, arguably ahead of its time? And how did you navigate the interaction with the reviewers and an editorial board?
That's a very good question, but it was actually very much more difficult in the beginning. People had difficulty in understanding the concept, and very, very careful by the editors and the reviewers with the message that was being passed on with the papers that were being published. To be honest with you, even though the first published paper on organ preservation by our group was in 1998 in DC&R, it took us 6 years to have a second paper published. At this time, it was in Annals of Surgery. It was very difficult to get that one published. And once that second one was published, I think a lot of people understood the concept, understood what we were talking about, and a little bit opened up the eyes and the arms of the journals. Now, I think we're on the other, as I mentioned before, I think we are on the other end of the spectrum now, because watching retina has become so much of a hot topic now that, this is one of the studies that reviewers and editors look for when they look in a journal. So, it was kind of tricky to get the story around the reviewers and the editors, because there was indeed a lot of resistance in the beginning. But I think that with the proper format and in looking at the data quite transparently, I think it gave us the opportunity to give the message in a very sensible and proper way. And I'm actually very, people look at me and say, what's happening to you, because you're now skeptical about it. I'm not skeptical about it. I'm just cautious, because I don't want to go and go and have horrible results with organ preservation because we're doing not properly. So I'm really cautious about how the way we look at the data, and particularly we are concerned about the local regrowths, because when you look at the patients who achieve a complete response and never have a local regrowth, these are home runners. These patients will do perfect. They will have almost perfect function. They will be very happy with the outcome. But the problem is with the local regrowths. Now, those 20–25% of local regrowths, those patients are a problem. They're a problem in terms of salvage, and they're a problem in terms of metastatic disease. Now, think about it, Vlad. A patient has a complete response and the tumor has grown back again. Now, is this tumor the same as it was in the beginning? We believe it's not. We believe that the tumor has grown back is probably worse than it was in the beginning. Plus, it was probably there during all time. You were thinking it was a complete response, but it wasn't, and it grown back again. So you've been 1 year with a patient with a tumor in situ, and you're now having to deal with the local regrowth. So we're really cautious now about the local regrowth. And the idea is that we have to find ways of decreasing the rates of local regrowths and detecting them very, very early on, because this is really one of the problems with the organ preservation programs.
Yeah, I think that the terminology certainly can be improved in terms of persistence versus, recurrence, because that probably would indicate the different pathophysiology. Thank you very much. There are a few other questions. I'll try to incorporate them into the next next section. I'm sorry. Can we have the last slide, please? Okay, good. So now we've got the last sort of segment of each session is a special guest. Obviously, Dr. Perez is our special guest, and he is a very accomplished surgeon and scientist. His CV speaks for himself. The blurb is only a very small snippet of what he's achieved. I personally have been fortunate enough to meet him, and one of the things that sort of stood out, and I think it stood out again today, is how warm and engaging he is in his manner. And I think he's very good at drawing people and inspiring people. Maybe that's a problem why so many people want to do watch and wait. You're too engaging. The other thing I just briefly wanted to mention is a special mention about Dr. Gama. Of course, she doesn't need an introduction in this session. I found it really interesting reading a reflection that she wrote in DC&R in 2018. In fact, both my wife, who's an endocrine surgeon, and I both read it, and then spent quite a long time discussing it, and I highly recommend that to people. But now I've got a few questions to ask you. So the first one being, obviously your team is the first team to kind of develop organ preservation. How is it, what does it take to run trials in Brazil? Is the ethics different to sort of the USA or Europe, and particularly with a new intervention? And does that affect specific sort of challenges of multinational, multi-center trials?
So these are very good questions, Vlad. Thank you for the introduction, first of all. Now, running trials in Brazil are a nightmare, as they are in the United States and in Europe. So we're trying to run a clinical trial here, looking at organ preservation using 2 different regimens. And it's been a nightmare because the regulations and ethics and all of the things that we have to go through are very difficult. Now, on the other hand, you have to understand that when this started, and it started not in the setting of a trial, and it was really patient driven, because patients refused in the beginning, a little bit like what happened to Nigra. When Nigra started the non-surgical management of anal cancer, it wasn't in the setting of a trial. Patients refused an APR because they had a complete clinical response. And this is basically what happened to Professor Angelita. A lot of the patients had a complete clinical response, and the discussion that he or she were going to be operated on and have a definitive colostomy, and with a chance of not harboring residual cancer within the resected specimen, was the trigger to start the organ preservation program. And patients were actually very keen on not having a surgical removal of the rectums unless they had at least some evidence that the disease was still there. Now, that was, some 30 years ago, where the regulations and the ethics were not as strict as they are now. But it was really, you have to understand that this is patient driven. This is not a doctor who is a surgeon and who actually gets money out of operations. Nobody was trying to push patients out of surgery. It was the other way around. It was patient driven. Patients didn't want an operation because if they had a complete response, they didn't want to end up with a definitive stoma. And after having a few patients with a complete pathological response after an APR, it was quite, significant and quite, intriguing to Professor Gama that this was probably not the best treatment for these patients. And plus, it was probably not in the best interest of patients themselves. So when you look at the data, you have to understand the context and the idea that this is really patient-driven and not surgeon-driven. We're not trying to, implement a technique here. We're simply saying some of these tumors may have gone away, and it's probably in the best interest of some of these patients not to have an operation. Does that make sense?
Yep, thank you. Now, how do you navigate sort of both the financial and the labor-intensive kind of algorithms for follow-up of these patients? Because it is different from resecting and moving on.
Yeah, that's a very good question, Vlad. So number one, you have to understand that the intense surveillance needs to be restricted for the first 3 years of follow-up. And the reason is that the risk of a local regrowth is the highest within those first 3 years of follow-up. That's number one. Now, when we looked at the data of costs, and the group from the Royal Marsden in London, Gina Brown was looking at this with us. When looking at the surveillance cost after a complete clinical response, even when you have a local regrowth and have to salvage these patients, and compare to the costs of surgery, complications, not to mention the robot, the cost of surgery is by far more expensive than an intensive surveillance program. Even when you put into the data the regrowths that you eventually have to salvage. So the cost at the end of the day, it's going to be more expensive to operate on everybody when you compare to a selective watch and wait approach. And there are several studies coming out now looking at data in terms of costs, both in the Netherlands, but also from England at the Royal Marsden.
That's very interesting. Sort of on that topic, what would you define as long-term watch and wait data? You talk about 3 years of intense surveillance. And do you think we're at a stage where we have long-term watch and wait data?
That's a tricky question. We used to say that patients need to be followed for life because we don't really know what may happen to these patients. But when you look at the large data sets and the International Watch and Wait database provides some insight into this, because we have some 800, 900 patients being managed by watch and wait. Now, the vast majority of local regrowths develop within the first 3 years of follow-up. That's number one. The problem is when you have a local regrowth, because then not only the local regrowth you have to deal with, but the metastatic risk is somewhat shifted towards a more longer period of time, because it's almost like resetting time zero when you have a local regrowth. Then the risk of distant metastasis goes on for 5 years after the local regrowth event. So to answer, to make a long story short, I would say we pretty much have long-term data. I think that the data that we have available shows quite nicely that the vast majority of local regrowths do happen within the first 3 years of follow-up, but we still have to look at very long follow-up before we make, robust and evidence-based decisions. I think we have to follow these patients at least 10 years and have to have sufficient evidence to say that 3 years is enough for a local regrowth, and perhaps 5 years after that, even if you have a local regrowth, is probably sufficient for the surveillance of metastatic disease.
Interesting, thank you. The more I sort of study your subject, the more I realize that I don't know, which is quite a demoralizing sensation. Now, in rectal cancer, do you think we know what we don't know? And what are some of the questions that you may have at the moment?
That's a very good point. I think Angelita always says that the more she studies, the less she knows about rectal cancer. And the truth is, I'm not sure we know what we don't know. I'm one of the ones in the group that is quite concerned about the local regrowths. I'm really intrigued by the local regrowths, and I'm not sure that by offering organ preservation to all patients, we are benefiting everyone, because the 30%, the 25% that develop local regrowth actually may be ruining the other 75%, because these patients do quite significantly worse than the ones who achieve a complete clinical response. So I think we have to look in the future for two things. Number one is we have to look for ways of predicting who is going to be a complete responder. That's going to be number one. And number two is we have to find tools that detect who's going to be a local regrowth quite early on, to make sure that we're not, compromising the oncological outcomes of patients who have a complete clinical response or an apparent complete clinical response, but then go on to have a local regrowth. So these are my two basic concerns. Ways of predicting response accurately, because we don't have them yet. And number two, ways of detecting the local regrowths early on, once patients have achieved a complete clinical response.
That's great. And do you, that's like grasping at the stars, I guess, but do you think that in biomarkers, I think someone mentioned that in the chat before, is it in imaging? Where should we invest our,
that's the beauty of it. We don't really know, and that's why so many, that's why there is still place and room for lots of studies. We thought that biomarkers were going to be the answer. So far, we have not been successful in looking for biomarkers in predicting response. Liquid biopsies, I saw I mentioned in the chat about liquid biopsies. The liquid biopsies are not there yet because they're not good for detecting minimal residual disease, so they have a lot of false negatives. And when you have a positive liquid biopsy, you're not sure whether the liquid biopsy is detecting residual cancer in the rectum or metastatic disease. So the biomarkers are still not there yet. There's a lot of hope in radiomics, and we're seeing a lot of studies being published in radiomics and artificial intelligence, looking at radiology information that is not visible to the human eye, and perhaps the computers are able to distinguish them. And we would be interesting to see what the outcomes of these studies bring us. But we're not there yet, and there's lots to study. And I saw also a question about different ways of delivering radiation therapy, such as the short course radiation therapy. I'm probably going to say that short course radiation therapy has no place in organ preservation, or very little place in organ preservation. But we're going to have to wait for the long-term, or at least short-term data from the ongoing randomized clinical trials.
Well, I think this is a fantastic conclusion. Thank you so much for your team to host this event. I certainly learned a lot. We've had more participants than any other journal club for the last over 18 months. So that's fantastic. Thanks everyone for tuning in, and it is recorded on YouTube. So if anyone missed it, or if you want to recommend it to other people, please do so. It's on the DCR YouTube channel. And again, I really appreciate you spending the time and effort to do this, and I hope to see you in person, maybe at ASCARS, if I'm allowed out of the country.
Definitely. Thank you, Vlad, for the opportunity, and on behalf of the group. And I want to thank Guilherme and Bruna for preparing the slides and giving the talks. I really enjoyed this, and Dr. Galandiuk, really, really honored to be here. So really thank you all for the opportunity, and Stephen for having the controls and everything, and Maggie for putting this together. Really appreciate the opportunity, and we would be happy to come back here again soon. All right.
Thank you for the wonderful journal club.